difficult, difficult balls to us, and it's becoming tough as a clinician to manage these difficult deliveries. So you have to keep on updating yourself. I'm trying to keep it in a cricket way because we just recently won the World Cup. So whenever we want to fight dengue, we need our two good batsmen, and that would be the oral fluids. The oral fluids can be in the form of your ORS, water, even your coconut water, lemon juice. All these are very much fine. The third batsman starts when the patient gets admitted in the ward. It might be an IV fluid, and crystalloid is the fluid of choice, maybe normal saline and ringer lactate. And then when the patient comes into ICU, then colloids take over. It might be a PRBC because we are dealing with very sick patients in ICU. Co-infections like enteric in monsoon season is common. Rickettsial is common. Electrolyte imbalance becomes important. And now most of the deaths in dengue are occurring because of fluid overload. So restriction of fluid after initial boluses is now very, very important. Oxygen ventilation and platelets are rarely to be used. And then comes your vasoactive medicines. Which are the extra players are steroids, IVIG, and FFP, which are an exception. They are not to be routinely used. Exception means once in a month, maybe, not for every other patient. And for these, we have empires. So clinical activity of the child is very, very important. Then the presence of rash, onset of abdominal pain, urine output has to be monitored. These are clinical parameters. What is new and studies that are showing is that for early detection of dengue hemorrhagic fever, focus can help you in diagnosing fluid in the gallbladder, in the abdomen, and in the lung. So it's not for fluid overload or restriction. It is for diagnosing fluid. Earlier, we used to say hypoalbuminemia or chest X-ray mein effusion aa gaya. Now we're saying focus can diagnose it much better. The two is the labs, out of which hemoglobin hematocrit is very important, platelets, liver enzyme, SVOT because of dengue hepatitis as well as ischemic injury. And over here, the focus will, in part 2, will take over your IVC distensibility, seeing the fluid responsiveness, heart ejection fraction, and then the lungs B lines. And the third empire would be the lactate, ferritin, PTINR, and co-infection. So with this in mind, and then comes the ballers. So the first is low TLC, disappearance of fever. It's a warning sign. Patients need to be closely observed in your OPDs. When the patient develops a capillary leak, he has to be admitted in ward. And if there is a liver injury and low BP, he goes into ICU, and complications will be the HLH and the fluid overload. So we all know there are three phases: febrile, critical, and recovery phase. Very common scenario: a 4-year-old child comes, the fever has disappeared, but the child has new onset abdominal pain and is looking dull. So this is a very important critical period which happens after the febrile period. So when the fever disappears, the critical period starts. And this is a period where the child will have low blood pressure, fall in platelets, rise in hemoglobin. And this is a time when IgM will start becoming positive. In the initial fever part, NS1 was positive. So you should know what test to send and how to diagnose this critical period. Because if you miss this critical period, the changeover from febrile to afebrile period, then the patient will go into prolonged shock and it will be very bad and the patients will come delayed to our ICUs. So the take-home point is disappearance of fever and some new onset symptom like dullness, vomiting, abdominal pain shows critical phase. And at that time, if you do a CBC, complete blood count, and if you get leukopenia, that means that you are dealing mostly with dengue in a dengue season. So definitely this patient admit in the ward because the hemoglobin is rising, leukopenia has happened, and there is abdominal cramp which is occurring. And this is how in 2009, the WHO classified dengue. So over here, if you see, they made it very simple. They told dengue with warning signs, that is abdominal pain, vomiting, liver enlargement. They're not discussing about plasma leakage over here. And they made severe dengue based on shock and respiratory distress, and they're based on liver enzymes more than 1,000 or impaired consciousness. So everybody loved this 2009 classification because it is very simple to implement. Over here, the expanded dengue syndrome was still not defined. But if you see the classification of dengue as a history from 97 to 2009, and the last classification was made in 2011. The only difference between these classification was 2009 did not have much about the dengue hemorrhagic fever, whereas 97 and 2011 was focusing on dengue hemorrhagic grade 1, 2, and 3 and 4. And 2011 defined what is called as expanded dengue syndrome. The difference between dengue hemorrhagic fever and dengue fever with hemorrhage is dengue hemorrhagic fever has nothing to do with platelets. It is to do with plasma leakage, rise in hematocrit, fall in albumin, presence of fluid in the abdomen, gallbladder, and lung is dengue hemorrhagic fever. So expanded dengue is isolated organ involvement in which like dengue liver failure, dengue ARDS, dengue myocarditis, dengue HLH, but not dengue mods. So expanded dengue syndrome is one organ severe dysfunction, and treatment of that will be organ specific and organ supportive. So this is the latest guideline given by Indian government in 2023. It has divided dengue without warning signs, without risk factors. Then dengue with warning signs, that is, we know persistent pain, abdomen, listlessness. But if the patient has dengue with warning signs plus high risk, like if the infant, obesity, pregnancy, on immunosuppression, then this becomes category B2, which is severe, definitely should be admitted, even if there are no symptoms. Severe dengue is the one which either has shock, either has significant bleeding, or there is acidosis and dyselectrolemia. This requires admission into PICU and tertiary care. So making it very simple, dengue with warning signs is B1, but dengue with warning signs with high risk, like infants and old age, again needs close monitoring and definite hospitalization. So sometimes we do this typhoid test also in dengue season. And then the dengue NS1 IgM can be negative in the crossover period. And then we are confused what to do now, whether it's dengue or it's typhoid. So the basic thing is typhoid should be not done. There are many false positive typhoid which occurs in dengue fever. And there is typhoid is not a gold standard. And we should unnecessarily do not do CRPs. So this is what we should do. Do not do typhoid, do not do Vidal, do blood cultures. But definitely in the government guidelines, they have mentioned that typhoid can occur. And if you're highly suspicious, then do the blood culture, start antibiotics. And if dengue comes positive, then you can stop your antibiotics. There is an official term called as dengue-like illness also, which includes your typhoid, which can be diagnosed with eosinopenia, leptospira in endemic cases, malaria, chikungunya will have IgM positive, and rickettsial should definitely be considered. Then dengue can present with URTI also, because ultimately dengue is a virus infection. It can have URTI symptoms. So in a dengue epidemic, do not be fooled that it is a viral URTI. It can be a dengue fever. So definitely in dengue season, keep a close watch out for even a URTI. If the patient comes to your ICU, which has no pulses in your emergency and is cold, it is very difficult to differentiate septic shock or dengue shock. Sometimes the septic shock can be vasodilatory, and dengue shock is usually high pulse pressure state, narrow pulse pressure state. So this is how you can differentiate, but it's not a gold mark. So what you should do is you start your antibiotics in which you are not sure if you're dealing with septic shock or dengue shock, and then you do a dengue test. And if dengue test comes positive, then you can de-escalate your antibiotics. It's important that you do not miss a septic shock. The fluid of choice in dengue would be normal saline or ringer lactate. But if you give lot of normal saline, it can cause hyperchloremic metabolic acidosis. And usually in dengue hepatitis, the lactate will not be metabolized. So it's not, if there's a liver dysfunction, be very careful when you are using ringer lactate. All guidelines mention dextran and gelatin as a colloid. Nobody mentions albumin, but albumin can definitely be given. No need to target your serum albumin level when managing shock. Albumin over here is used as a colloid to retain the fluid, not to target the serum albumin level. It's a more of a prognostic marker and it's a blood product. So be very careful. Dengue is a very dynamic disease. Rational use of fluids are important. Avoid prolonged shock is the first part which we highlighted. But the second part which causes mortality, which we are seeing, is because we start fluids and forget to de-escalate. So avoid fluid overload. So basically, if a child has a low blood pressure, then you give a 20 ml per kg bolus over 15 to 20 minutes, and then see if the patient has responded and shifted to compensated shock, that the blood pressure has become normal. Then you give 10 ml per kg per hour, and then accordingly, you can come down on the fluids to 7 ml, 6 ml, and further down. But if the patient has no shock and you are admitting just in the ward for fluid management, then you can use this oral plus IV fluid maintenance plus 5% formula. I'll come to that formula. This is how we do it in ICU. We look at the IVC, which is a tank of the body. We look at the heart and we look at the pipes and then decide how much fluids to be given. But that is for tertiary care level. This is what we are highlighting. Initially, there will be high fever spikes. And when the fever spikes are going down, then we will get the blood pressure, which is going to fall. And this blood pressure is a narrow pulse pressure, which is happening over here. This is the time that you start giving fluids. So you have 3 periods: the febrile period, critical, that is the 2, and the recovery phase. So this is a period where you start giving fluids in an escalatory fashion, depending on the hematocrit and the urine output. And if the hematocrit and urine output are okay, then you de-escalate the fluids also. So this is very important that you give optimal fluid in these 3 or 4 days of critical period. Otherwise, if you do not de-escalate, then the patient will go into a fluid overload state. So both fluid overload is bad, as well as prolonged shock and underdiagnosis of critical phase is also bad. So if the patient is in ward, start from 0.5, 3, 5, shift to ICU when it reaches 7, and ICU 7, then come down to 5, 3, shift to ward 3 and 1.5. This is one scenario when the patient is in ward, comes to ICU. The second scenario, patient comes in shock only, then you start at 20, 10, 10 to 5, 5 to 3, and see period of 6 to 12 hours. This is how the dengue shock is so dynamic, and we should not be so liberal in continuous fluid challenges. So this maintenance plus 5% is if the child is 20 kgs. So the deficit of 5% is 50 ml per kg, that is 1000 ml, and the maintenance is 1500 ml. So the total fluid is 2500 ml. This 2500 ml has to be administered over 48 hours in a non-shock patient. This will come out to be somewhere around 3 ml per kg per hour. This is what they are saying. There should be an upper limit of fluids in the ward that should be given. But if the patient is deteriorating, you can increase the fluid input. But if it crosses beyond 3 ml per kg per hour, it's time that you become vigorous in your testing and managing your hematocrit, platelets, and your urine output, and maybe shift to ICU. But if the fluid is less than 3 ml per kg per hour and the patient is okay with a steady level of hematocrit and the platelets which are okay and not drastically falling, you can manage these patients in ward also. But if there is prolonged shock, always remember the ABCS. That is your acidosis, which can be part of your hyperchloremia due to sodium, or it can be a part of renal dysfunction or prolonged shock. Bleeding is your packed RBC. You should consider. C is the hypocalcemia and S is sugar, that is hypoglycemia. So these are the confounding factors that you have to treat in a patient of dengue, prolonged dengue shock syndrome. What is important is do not overload a leaking vessel. So vessels are leaking. There is no point of giving multiple fluid challenges. Be very careful. Target a urine output of 0.5 ml per kg per hour is okay. If it reaches 1 ml per kg per hour, you can decrease the fluid intake. So void volume chart is very important. Cut down at a recovery phase. Sometimes the patient is okay, but we do not cut down on the fluid. So if you come down to half maintenance, that is 1.5 ml per kg per hour, that means the child is doing beautifully well. And this 1.5 ml per kg per hour is inclusive of both oral and IV. It does not mean only IV. Give blood when indicated. Second is there is an obesity epidemic which is happening in some parts of India. So it's important that the fluid should be given on ideal body weight, and how to calculate the ideal body weight is very, very it's not taught in many places. So basically use a height for weight chart and weight for age chart. So this is actual boy weight is 90 kgs. What is the ideal body weight? So what we do is we have taken the actual height, that is 150 centimeter. We see where it crosses the 50th centile. Then we draw a line to the weight 50th centile and see what is the body weight. So the ideal body weight comes around 41. So if you were giving fluids at the for 90 kgs at 10 ml per kg, that is 900 ml, it is very high. So the actual fluid requirement is only 400 ml per hour. So you see the difference in obesity. So that's what we are saying. With a 60 kg child, the fluid rate will be somewhere around 180 ml per hour, but in 40 kg, it will be 120. So it's a big difference in the fluids that should be given in dengue, in obesity. So sometimes the difference is too much. Ideal body weight is like 41 and actual is 90. So we tend to think that we might be under high, not giving adequate fluid boluses. Then there's something called as the adjusted body weight, which is the mean between the ideal and actual body weight. So 41 and 90 ka half is 65. So you can give fluids as per 65 also. Then comes about mefenamic acid, naproxen, aspirin for fever. Remember, fever in dengue should not be controlled with mefenamic acid, aspirin, because these are all NSAIDs. These can cause a fall in platelets and also platelet dysfunction and bleeding. So it should not be used, should not be used. Control fever by paracetamol, or you can use peptide sponging. Do not unnecessarily give platelets. Keep a platelet count of more than 10,000. That is what they are saying, but there's nothing called as prophylactic platelet transfusion unless you're putting a central line or there is significant bleeding. Nose bleeding is not considered any bleeding. Significant bleeding means a fall in a hemoglobin of 1 to 2. I've covered the important points of dengue in the time given. Any questions? Hello? Or was it too fast? Sheikh sir, you want to point out something in dengue?
Maninder, first is that our Jain, Dr. Jain is there, our moderator.
कुछ नहीं होता सर, आप हो moderator. You are the senior most
Okay.
here, sir.
No worries. So, Maninder, exceptionally well done. I mean, what's beauty about your presentation is it's a combination of evidence-based and what is at ground, practicality. So you covered from practical point of view, that's number one. Couple of things that I just want to learn from you, that you said collide and collide in the form of PRBC in ICUs. So what are the indications? I mean, I would like to be clear with regard to use of PRBCs in dengue
So
in
if there is
ICU as a
uh,
collide.
not as a colloid, PRBC is not a colloid. Whole
Ha,
blood is a
ha,
more of a colloid. PRBC is
ha.
for maintaining the hemoglobin level if there is persistent bleeding, fall in hemoglobin in a dengue
Yes.
shock patient.
Yes. So that's number one I wanted to clarify. Second thing is focus. Definitely, there is a great role of focus, but can you stratify? It is desirable to have the focus, but then we have our own limitations, and we have to overcome the limitations. That we agree. But given the scenario that we have, there is a definite utility of focus. Definite utility of focus, and we do say that focus should be used. That's number one. And Maninder has highlighted very well. Pawan has joined us. Pawan,
Yeah.
can I come to continue?
Yeah, yes, please. Please, sir, go ahead.
Yes, yeah, yeah. Number three, at one point of time, Maninder, you rightly said, but I would like to add or understand from you. You said capillary leak continue in ward.
Capillary
So
leak,
continue
not
ward management.
every capillary leak does not need ICU management. Capillary leak can be managed in ward with frequent close monitoring. All capillary leaks should not be admitted into ICU.
So So,
Pawan, few questions
Maninder,
are there
yeah,
in the chat box, so
yes.
kindly address those questions also.
So here we go. There was one question about albumin versus FFP. So there was a thought,
Yes.
if albumin is expensive, not readily available,
Yeah.
can we go for FFP? That was one of the questions. And that is asked by Dr. Atindra Jain.
So overuse and abuse of FFP should not be done. You have to remember FFP is a blood product or actually a blood component. Albumin is a blood product. It has less side effects, though it is expensive. But what we are trying to tell you that 5% albumin you can make from 20% and overall it will be less expensive. And second is FFP has can cause hypocalcemia and it is very cold. So should be avoided. And because it's a blood product, TRALI can happen, transfusion-related lung injury. So overuse of FFP is an obsolete phenomena, should not be used. And some people say, because I'm attending adult conferences also, they are giving left and right FFP, saying it improves the platelet count also. I don't know from where these concepts are coming. They are saying we are doing a sort of plasma exchange by giving FFP. You're not doing a plasma exchange. You are giving a blood product to a patient who doesn't require a blood product, which has significant side effects. So should not be used, should not be used, should not be used.
Another question is from Dr. Sakshi. She says, should we consider ideal body weight for patient in fluid overload state? And she says possibly iatrogenic. The patient who has been referred to them, the patient might have been edematous puffed up. So her concern is, shall we take ideal body weight at that point in time to sort of give the fluid management?
So what is recommended in all guidelines that ideal body weight for obesity and actual body weight for undernourished. There is no role for obese body weight to be given for fluids. Then you're going to give extra fluids to the patient and he's going to go into overload. The body does not require so much amount of fluid. So stick to ideal body weight for obese patients. Then you will be actually thanking me, saying their patients are not going into ARDS.
So we'll take this last question from Dr. Naresh. He asked, if hemoglobin is low, but fluid overload signs are also there, what is the role of Lasix if PRBC to be given?
Okay, so now the question is very interesting because so much fluid has been given that it has caused dilutional fall in hemoglobin. So at this point, fluid restriction and Lasix would definitely be beneficial, but keep on monitoring your hematocrit. So a rise in hemoglobin will happen and your urine output because now recovery has started. That's why the patient is now okay. That's why you're going to give Lasix. But if the recovery has not yet started, patient is still in shock and fluid overload is present, that time restrict fluid and that time you may give PRBC if there is a fall in hemoglobin.
So, and Maninder, one last, how do you make use of hematocrit if, sort of how frequent you do while you're managing the patient in PICU, in the ICU setting?
Right, so there are 4 sets of patients. One patient is in ward, we do twice daily hematocrit. One patient comes into ICU, he's not on oxygen support, he is not on any vasoactive support. We do twice daily. But if the patient has an escalating fluid requirement in ICU, escalating means it was on 10 ml per kg and now we have to go up to 15 ml per kg and the shock is not resolving, then we may even do second hourly. But if the patient's fluid is now become stabilized after 2 or 3 boluses, then we might do 6th hourly. Another caveat is the urine output. If the urine output is happening, then it's an indirect marker. You might not need to do so many VBGs for hemoglobin. So urine output of 0.5 ml per kg per hour is good enough. Then you can do twice or thrice daily also. A worsening shock, you do 4th or 6th hourly also.
Thanks, Maninder. That was a wonderful talk, and you answered so many questions. The whole, so it seems audience has really enjoyed your talk. So I think we will go to the next
Excellent
talk.
talk. Just I want to comment, Dr. Maninder, this is one of the best talk we have encountered with this dengue particularly. So thank you very much, Maninder, for joining and for sharing your knowledge. Thank you once again.
Dr. Kiran, I just want to ask one small. Dr. Maninder, will you highlight a few words about the vaccine for dengue? Recently,
so vaccine for dengue, sir, I'm not an
Vaccine for-
expert of vaccinology. So, but my friend in Sri Lanka, he was a part of it, Dr. Lal Kumar, I think so. So it's going to come recently. They are doing some trials. So I don't know when it will come. I'm not the expert on vaccinology, sir. Sorry.
Our Sarabhai sir is vaccine expert from Chhattisgarh. He is known for his vaccine knowledge. So that's why he's asking about the vaccine for dengue.
It will come, I think so, in next 1 or 2 years, sir. It's in the, I think Sri Lanka will get it first.
Okay. Thank you. Thank you, Maninder. Pawan, please continue with your next talk. This is your talk, so you have to start with your session.
Where do I go? I have to share my screen.
Yes.
So I have to first open my PowerPoint. So that I've opened. Now, how do I share the screen of my...
Yogesh,
I
please
go
give me.
here. Yeah.
Yes, this is starting.
Is it there?
Pawan, you can see in the bottom there is an option green colored share
No.
screen.
Has my screen shared now? You are screen sharing it shares.
But you have to open your slides, open your presentation first, then you share.
Just a moment. Give me a sec. Is it now there?
It is not
Yes,
open. So just close it. And now open your slides, open your PowerPoint presentation. And after that
there?
you share. Yes, now it is. Now make it full screen. Slideshow.
Yeah.
Yes. Are we there?
Yes.
Yeah.
It's full screen now.
So now today we'll be discussing pediatric septic shock, especially how it has changed with the new scoring system. And we mainly hinge on the update in 2020 on the sepsis guidelines and the current scoring system, which is the Phoenix score for the diagnosing sepsis and septic shock. So, as we all know, shock is an acute circulatory dysfunction leading to inadequate delivery of oxygen to tissues. While sepsis is life-threatening organ dysfunction caused by a dysregulated host response to infection. While septic shock in children is severe infection leading to cardiovascular dysfunction, including hypotension, need for vasoactive drugs, and presence of impaired perfusion. Sir, is there a way I can put the side screen in a... Yeah. Next is just a brief how the evolution of sepsis definition occurred. In the past, all the sepsis definitions were based on the adult guidelines and the various iterations of sepsis. And its definitions came in 1992, 2001, and 2016. The last iteration known as sepsis 3, wherein they have just taken sepsis and septic shock and done away with severe sepsis. If you go further, this is a small table showing the last 2005 International Consensus Conference on Pediatric Sepsis Definitions, in which SIRS, or the Systemic Inflammatory Response Syndrome, is the abnormal temperature along with tachycardia or tachypnea with derangement in white cell counts, sepsis, which was SIRS with suspected or proven infection, and severe sepsis with cardiovascular dysfunction or acute respiratory distress syndrome or 2 or more other organ dysfunctions, along with septic shock. Now, most recent definitions of sepsis in children and adults are 2005 iteration of pediatric sepsis nomenclature, then 2016 sepsis 3, which is the adults, where they have done away with severe sepsis. Now, what happened that the Definitions for pediatric sepsis were established in 2005 without data-driven criteria. It was mostly adapted with some modifications from the adult guidelines. And it is unknown whether the adult sepsis 3 definition meets the needs of providers caring for children, because children are not small adults. So then came the SCCM made a task force, and wherein they developed a Phoenix sepsis score, taking in various countries across all the continents and including both high resource and low resource setups, wherein there are 4 organ systems involved: respiratory, cardiovascular, coagulation, and neurological. And sepsis is when you have a suspected infection and Phoenix sepsis score of more than 2 points. And septic shock is defined when there is sepsis with at least 1 or more than 1 cardiovascular point. So as you can see in respiratory, they've taken simple things like PF ratio, either by ABG or with the simple pulse oximeter, the SF ratios, wherein you will allot 1 point if your PF ratio is less than 400 or SF ratio is less than 292. And 2 points is allocated if the patient has a PF ratio of 100 to 200 on invasive mechanical ventilation, or SF ratio of 148 to 220, and it will be worse when PF ratio is less than 100 or SF ratio is less than 148. While in the cardiovascular, they will allocate 1 point for 1 vasoactive medication, and if the lactate is between 5 to less than 11, and 2 points when there are more than 2 vasoactive medications with lactate more than 11. And these are the 5th and 50th percentile of mean arterial pressures. And on the coagulation parameters, the importance is to see clinical or a subclinical DIC, wherein platelets, D-dimer, and fibrinogen are there along with INR. So if it is less than 1 lakh, and platelets are less than 1 lakh, and INR is more than 1.3, and D-dimer increase more than 2 with a fibrinogen reduced to less than 100, they will allocate 1 point. The neurological component is again a clinical score, which is the Glasgow Coma score, which is when more than 10, no points are to be allocated. And when the score is less than or equal to 10, then 1 point is given, while if the patient is comatose with fixed pupils bilaterally, then 2 points are allocated. So this is the flow diagram that in an unwell child with common or a suspected infection, you screen for sepsis and assess for organ dysfunction at the same time. There are simple parameters for assessing the organ dysfunction, which we'll come to know as we move to further slides. So if you have a Phoenix score more than 2, then it is then the patient meets the criteria for sepsis. And if this sepsis score has at least 1 point from cardiovascular dysfunction or more than 1, then the patient meets criteria for septic shock. So clinical considerations are need for antimicrobial treatment and need for organ support. So the previous SIRS-driven sepsis diagnosis is no more there, because it's a very clear and an important diagnosis wherein antimicrobial treatment is very important, and also to assess for organ support. So sepsis diagnosis is operational as 2 points or more on the Phoenix sepsis score and septic shock as sepsis with cardiovascular dysfunction. So what are the clinical manifestations? If you see the identification part of sepsis, the first thing which comes into light is either there will be altered body temperature. This is the commonest thing which brings parents to you, or in the ED or in your clinic. And then signs of inadequate end organ perfusion are brain, kidney, skin. On brain, you'll have abnormal mental status manifested in the form of apprehension, anxiety, agitation, obtundation, or coma, while there might be oliguria if kidney perfusion suffers. And if skin perfusion is less, then the capillary refill time might be more than 3, it will be prolonged, or there might be a flash capillary refill. There might be pallor or mottled skin as well, along with metabolic acidosis and elevated serum lactate. As I told, altered body temperature is something which brings the patient to the ED or to the medical attention. There might be tachypnea, tachycardia, abnormal pulse which might be diminished, weak, or bounding, and hypotension is a late but very important sign to act fast. Now the sepsis bundles and quality improvement initiatives were there, wherein how to recognize, then resuscitation bundle, then stabilization bundle and performance bundle. They were the part of QI initiatives of any center. In 2020, they have taken this term as screening, diagnosis, and systematic management, wherein you implement a systematic screening for timely recognition. Consider using blood lactate values to stratify into low versus high risk of septic shock or sepsis, and implement a protocol guideline for sepsis-related organ dysfunction. And 4, obtain blood cultures before starting antimicrobial therapy, given that it does not delay the antimicrobial administration. So initially, we went through how the guidelines have evolved, and we saw the 2005 pediatric guidelines, the WHO definition, which is based on the 3 clinical parameters, and the sepsis 3 definition of the adults, and new revision, which is the Phoenix score. And it was sent across the world for survey to the various experts. And if you see, the green stands for strongly agree, and the light green mint color for the agree. If you go and find the new revision has the highest, agreement for the strongly agree component based on recognition, early recognition, and the correct disease classification, prognostication, benchmark, epidemiology, and enrollment. Mind you, this is very important because enrollment brings the patients across the globe on a sort of a single platform where it is easy to analyze the data. Then this is the classical algorithm, which was a 2014 update published in 2017. And this was a time-sensitive, goal-directed therapy kind of thing, where you see that by 15 minutes, you are already you have practically done the fluid resuscitation of 60 mils per kilo. The fluid and vasoactive and various other things have got newer understanding and update in the 2020 guidelines and the 2024 classification. But it is good to remember as a framework that recognize the sepsis, and with the help of your action and reassessment, find out whether it is fluid refractory, whether it is catecholamine resistant, or whether it's a refractory or a persistent catecholamine resistant shock. So we'll see in the next slides how the thought process has changed in the evidence, in the light of new evidence in terms of septic shock management. So this is the initial resuscitation algorithm for children, which was published in 2020, in which first you screen the child for sepsis, and after systematic screening, find out whether the child fits in suspected sepsis arm, wherein within the first 3 hours of suspicion of sepsis, you have to complete this initial steps. And if diagnostic this diagnostic evaluation is focused towards finding out whether there is a sepsis associated organ dysfunction. While if you have clinical signs of septic shock, within the 1 hour of initial recognition of septic shock, obtain IV access, blood culture, start antimicrobial therapy, measure lactate, administer fluid boluses if shock is present, and start vasoactive agents if it is a fluid refractory shock. In addition, it has been found that in a good number of septic shock patients, there might be a pediatric ARDS evolving. So assess for pediatric acute respiratory distress syndrome in sepsis patients is very important, and infection control is important, fluid and vasoactive titration based on action, continuous reassessment, reaction, that kind of a thing. So advanced hemodynamic monitoring where possible, and so some advanced therapies are also mentioned, meaning the extracorporeal life support or ECMO, where it is a refractory shock, catecholamine resistant, and other reversible causes of shock have been excluded, and patient is not responding any kind of therapy. That's a desperate situation for extracorporeal life support. Now, how do you do fluid and vasoactive therapy management? So there are 2 arms. There are healthcare systems without intensive care and healthcare systems with intensive care. So it is quite possible to administer therapy to the patients in septic shock in both the setups, wherein you have a dedicated PICU or wherein you don't have a dedicated ICU. So if the patient has signs of shock without hypotension, Then do not give fluid boluses unless there is a clear-cut scenario wherein fluid loss has been seen, for example, in diarrhea. Start directly the maintenance fluids, monitor hemodynamics closely, and consider vasoactive inotropic support if available. Adrenaline is one of the very simple drug, cheap, easy to prepare, and can be given peripherally to start with. While if the patient has abnormal perfusion with hypotension in a non-ICU setup, and if signs of fluid overload are absent, then give fluid boluses in 10 to 20 ml per kilo. So if you see the range is 10 to 20, we'll further see the merits of giving allocodes in 10 ml per kilo. And to assess hemodynamic response to fluid and repeat boluses, 10 to 20 ml per kilo until hypotension resolves or signs of fluid overlap develop. The signs of fluid overload are new onset hepatomegaly, then new Krebs or Ray's, and the jugular venous pressure is high, or you are seeing on an X-ray that it has worsened. Then assess cardiac function. So point of care, comes into action here, and consider epinephrine or norepinephrine if hypotension persists despite 40 ml per kilo, or sooner if signs of fluid overload. Mind you that the vasoactive drug infusions have to be started concomitantly, independent of fluid boluses. If you see that after initial fluid boluses, child is not showing signs of improvement. Then in healthcare systems with ICU, and if signs of fluid overload are absent, one should give fluid bolus of 10 to 20 ml per kilo, reassess after each fluid bolus, and consider fluid bolus of 10 to 20 ml per kilo up until 40 to 60 ml until shock resolves or signs of fluid overload develop. Assess cardiac function. It is presumed that there are means of advanced monitoring as well as point of care ultrasound to assess the cardiac function. And consider now the option. It depends on the unit, what it wants to start, but there is a caveat that start epinephrine if there is myocardial dysfunction, or epinephrine/norepinephrine if shock persists after 40 to 60 ml per kilo of fluids, or sooner if the signs of fluid overload develop. So here the fluids are given dose based on ideal body weight. Now, if shock is resolved and perfusion is improved, do not give more fluid boluses. Consider maintenance fluids once the shock is resolved, and monitor for signs and symptoms of recurrence of shock. Now, hypotension in healthcare system without ICU is defined as less than 50, 60, and 70. But I would just very humbly make a point that it should be like 70 for the infants, and then we have the PALS formula of 70 plus weight 2 into weight that will serve better while we are managing the patients. Now, antimicrobial therapy, as we discussed in our initial algorithm part, wherein within first hour of recognition of septic shock, the antibiotics have gone in, and there are studies which show that with each hour of delay in antimicrobial administration, the mortality increases. So start with empiric broad spectrum antibiotics likely to cover likely pathogens. So if you have pneumonia or meningitis or skin and soft tissue infection, then you know that based on the local regional data, you can very well start the empiric broad spectrum antibiotics. And narrow antimicrobial coverage once culture and susceptibility reports are available. In children with immune compromise, meaning the ALL patients or the patients who are on immunosuppressant medications, post-liver transplant, post-renal transplant, etc., or immunocompromised because of any reason, use empiric multi-drug therapy. And determine antimicrobial duration based on site of action, microbial etiology, clinical response. So if there is an abscess, then you have, depending on if it is a pharmacologic sanctuary, the penetration of drug is less, you have to give prolonged antimicrobial therapy. And these are the various scenarios where, depending on your institutional protocol, one can start the empiric antimicrobial coverage. Now, volume and type of fluids is very, very important. If PICU is available, we discussed that administer 40 to 60 within the first hour, and monitor for signs of fluid overload. And if PICU is not available, then the ceiling is a bolus of up to 40 ml per kilo. It is good to give in 10 ml per kilo because you can frequently reassess and you will very soon know that the patient is getting at the verge of fluid overload, and the severity of fluid overload can be avoided if we take smaller aliquots like 10 ml per kilo. And use balanced or buffered crystalloids rather than albumin or 0.9% saline for initial resuscitation. So ringer lactate is something which is easily available to us, not very expensive. And avoid hexaethyl starch or gelatin in acute resuscitation. Now, choice of vasoactive drugs, use of epinephrine rather than dopamine, and norepinephrine, again, rather than dopamine. So dopamine, which used to be the first line drug a decade or back, has been totally replaced with epinephrine and norepinephrine in light of emerging evidence. And so the epinephrine and norepinephrine are first line vasoactive drugs guided by clinical preference, patient physiology, and local factors. So if there is an active unit which after fluid resuscitation can see that there is a component of myocardial depression and the patient has not responded to fluid resuscitation alone, they might as well start epinephrine. And if on the other hand, they have found flash capillary refill or sort of a hyperdynamic state, they might as well start norepinephrine. Now, there is a ceiling to maximum dose of both epinephrine and norepinephrine, and there might be a no response scenario wherein it is prudent to add. Now, you might be forced to add vasopressin and titrate catecholamines. And while you are giving vasopressin, please monitor the skin. Even, vasopressin can lead to a lot of ischemia. So that needs a very careful titration. And inodilator like mindrolone may be given if there is persistent hypoperfusion and cardiac dysfunction despite other vasoactive drugs. Now, when we were doing our PG, these drugs were told, no, please don't give peripherally. Now there is clear evidence when there was COVID in patient with post-COVID MISC. Peripheral epinephrine and norepinephrine were given in these children. It was found that they are safe to use even via periphery. Now, suggested dilution is by the rule of 0.3 for adrenaline 50 ml diluent, because in inotropic doses, it is actually inodilator and it will not lead to vesicant there. And 0.8 mg of norepinephrine is to be dissolved in 50 ml diluent, and based on body weight, you have to then calculate the infusion rate. That's the dilution for norepinephrine. Now, it is not without caution that you can do peripheral epinephrine, norepinephrine. There are risk factors for adverse events, especially if the child is young. The caliber of the vessel is going to be small. And if you're using small caliber cannula, and the site of IV site is hand, and there is increased severity of illness, and there is longer duration of peripheral infusion, or if you are forced to give higher doses of dopamine or more than 0.1 mic of epinephrine or norepinephrine via the periphery. Hemodynamic monitoring, the hemodynamic endpoints of shock treatment is to target a mean arterial pressure of 5th to 50th percentile, which is given in the charts which are easily available, and do not use bedside clinical signs in isolation to categorize septic shock as warm or cold, because advanced monitoring has shown that this can be fallacious. Use trends in blood lactate levels and advanced hemodynamic monitoring. Now, with advanced hemodynamic monitoring, there are two schools of practices. One, units which are very high resource units, they have just cardiac output monitors available to them, while there are units who will just do invasive blood pressure and point of care ultrasound. So that is their hemodynamic sort of monitoring to guide the resuscitation at the bedside. Now, patients who fail to achieve vital signs normal for age and inadequate perfusion is persistent, they are considered high risk for deterioration and should receive ventilatory support even before they have clear-cut signs of respiratory failure. So consider intubating children with fluid refractory catecholamine resistant septic shock without respiratory failure. Do not use etomidate when intubating. That can lead to, even single dose might sometimes lead to hypotension, which may be refractory. And consider a trial of non-invasive mechanical ventilation If there is evolving pediatric ARDS, which in the view of clinician, the non-invasive mechanical ventilation will help. And moreover, you can always reevaluate within 2 hours whether NIV is working or not, and one can immediately go for the invasive mechanical ventilation plan. If severe sepsis-induced PRDS uses high PEEP, the principles of management of ARDS with shock will remain same, which includes high PEEP, more than 10, prone positioning, neuromuscular blockade, and prone position, all those things. Now, sedation, analgesia, and positive pressure ventilation prior to adequate volume resuscitation may cause profound drop in preload and precipitate severe hemodynamic instability at the time of intubation. So we should be ready, attached with epinephrine infusion prepared and attached to the cannula of the patient, and maybe started. And the drugs which are usually good for induction in septic shock is ketamine or low dose of fentanyl. Now, in catecholamine resistant shock, patients with fluid refractory. So these are patients who are fluid refractory, who remain shocked despite epinephrine and norepinephrine. So as we discussed, we can start vasopressin in doses of, 5 milliunits to 2 milliunits, 20 milliunits sort of scenario, and add inodilator like milrinone if the child remains in shock with evidence of low cardiac output. Now, there might be, despite this efforts, there might be a patient whose shock is refractory to management. So try to unravel the, hidden morbidities like pneumothorax, pericardial effusion, intra-abdominal hypertension, ongoing blood loss, presence of infected source, and overt adrenaline insufficiency. Consider hydrocortisone. You may consider in refractory shock if you see the scenario that this patient has been on acute or chronic steroids, and he might require hydrocortisone. Now, providers trained in point of care ultrasound can assess fluid responsiveness with the help of IVC distensibility and cardiac output estimated by LV function. So this is the trend is important, and the exclusion of pneumothorax and pericardial effusion at the bedside. This 4 diagnoses can be very easily made at the bedside. However, we cannot forget that how the patients come to us, they come from pre-hospital and emergency departments to ICU. And after a battle in ICU against this septic shock, when these patients are discharged, they have long-term outcomes, quality of life issues, then post-traumatic stress disorder rehabilitation. So patient-centered care and family support even after discharge is of paramount importance in this pediatric sepsis journey. So to conclude, sepsis is one of the leading causes of morbidity and mortality worldwide. It is in the priority list of WHO. And mortality is associated with delayed recognition and treatment. And here comes the value of the bundles, early recognition and application of bundles. So surviving sepsis campaign advocates 6 steps: immediate IV access, collect blood culture, do not delay antimicrobials, measure lactate, administer fluid boluses depending on the setup you are, and start vasoactive agents if shock persists. The Phoenix score may achieve the same goals for children across diverse settings, both the low and high resource setting. You just need a printout, put it in the file of the patient, and keep on doing the Phoenix. You can very well do Phoenix sepsis score and set up the criteria for septic shock in the patient. And what SOFA score has achieved for adults, Phoenix score, sepsis score will do it for children. That is what is our hope. Syrup lactate may not be available in some settings. However, it is included as essential test whenever possible, even in low resource settings. Now, precision therapeutics is an emerging specialty, and it's a subset of patients, especially with multi-organ dysfunction and who have phenotypes wherein they show suboptimal response to antibiotics, fluid vasoactive medications, and supportive care that remains to be unraveled. So it's a very exciting field to come up. We already have bundles of care and guidelines to look after our patients. And mind you, the septic shock, the mortality from septic shock has practically remained stagnant in the Western world. It is us in the lowest resource setting or the developing nation wherein with the help of these bundles, we have the opportunity to reduce the mortality from septic shock. So if that message goes in and we can adopt this newer guidelines in our own settings, be it low resource or high resource, we can definitely make a difference. With that, thank you very much.
Well, Pawan, can you stop your, yeah.
Yeah.
Yeah, thank you, Pawan. I'm sorry, I will not be able to start my video because there is some problem with the bandwidth. However, excellent presentation by Pawan with regard to the topic which was given to him as septic shock, what is new. So actually, he was really to the point what is required to be delivered so far, what is new in septic shock. However, from the general pediatric point of view, we'll try to make it as simple as possible. And I feel what is the crux of your entire presentation is number one, early recognition of sepsis. It's very important. So early recognition of sepsis at any level, whether it is at nursing home level, whether it is ER level, ward or otherwise, the early recognition is very important. Number two is your once you recognize the shock, it's very important to understand whether it is hypotensive shock or compensated shock. So shock does not need the blood pressure to go down. The blood pressure to go down when the bus is already left. So you have to treat the shock, identify the shock before the shock hypotension sets in. So that's number one. Number two is like, we have to, once we have the shock, the basic management, airway, breathing, circulation, and then that's number two. Number three, having had the shock, have a good vascular access. Try to have the two good vascular access, wide bore needle as well. And at the same time, once you have the vascular access, draw the blood for your labs, including your HGT and other things. The host of list are there. So once you do, then you have what is called as volume resuscitation. So volume resuscitation in hypotensive shock and volume resuscitation is normotensive shock. Hypotensive shock, simple push and pull. So we have to bring the hypotensive shock to normotensive shock. That's very important. And then as you rightly said about the volume and all those things. That's it. Then next is your early antibiotic. Early institution of antibiotic is very important. Earlier it was 1 hour. Now it is if you have 1 hour, 3 hour based on your category. So but early identification of our source control and early antibiotics. That's one. Next is your early vasoactive agents. So suppose you have given 40 ml, 60 ml per kg, and still the patient is this is fluid refractory shock. So you can come in the vasoactive agents. Choice is yours: epinephrine, non-epinephrine, that you can take. Important thing which has come up is use of vasoactive agents from the peripheral lines from the dilution. You can make double dilution or four-time dilutions. So you can use the peripheral lines, buying your time for the next, including if your facility permits the central venous access. And watch for refractory shocks. What are the causes of refractory shocks? Which includes you remember, like the pneumothorax and if other things are there. So look for the refractory shocks. And important is always the part of this assessment, intervention, and reassessment. So the reassessment is in terms of clinical therapeutic endpoints of shock, which includes improvement in temperature, improvement in heart rate, improvement in blood pressure, and one of the most important improvement in end organ perfusion is mentation and urine output. Urine output is a very good marker for shock reversal, unless you have nephropathy. So urine output. So these, and of course, if you have a lactate improvement. So these are the general common things which are required to understand, not to an intensivist, not only to an acute care management individual, but to everyone who is practicing pediatric, that we have to understand. So this is from my end with regard to Pawan's presentation. Excellent presentation, Pawan. Thank you.
Thank you, Sheikh sir, and excellent presentation by Dr. Pawan, very exhaustive and rightly by Dr. Sheikh. And thank you very much, both of you. And now coming up to the very important session of the panel discussion on IV fluids. So I request our Dr. Maninder to start with the session. And Dr. Pawan, in meanwhile, please introduce our all the panelists in brief.
I'm honored to introduce our respected Dr. Sheikh Minhaj sir, who's a very senior consultant, very experienced person from Lilavati Hospital, Mumbai. And as you already know, people people already know him. He needs no introduction. And with the moderation he has done, you would have come to know that how he exactly knows the gist of the management in the common critically ill patients they deal with. So it gives me immense pleasure to welcome him to this panel discussion. We have our own Dr. Satyen, Gyani, who's a senior consultant and intensivist, and he has been practicing critical care for last close to 15 years. Welcome, Satyen, and we are very happy to share your practice, your knowledge, which you will be doing on this platform today. I'm very happy to welcome Dr. Nikhil Kedia, a very dedicated pediatric intensivist from Star Children's Hospital, Bilaspur. Welcome, Nikhil. Nikhil had almost a decade of work at UK, and he brings all his knowledge and best practices from that part of world to our own country, our own state, Chhattisgarh. Then we have one of another esteemed panelist, Dr. Maninder Dhaliwal, who's a senior consultant intensivist from Amrita Institute of Medical Sciences, Faridabad. Welcome to you all. Maninder would be moderating this session. I'm sure he has got very interesting cases, and our audience will be extremely happy to participate in his case discussions. So over to you, Maninder. Please start.
Hi. So, first of all, it was a wonderful lecture, Dr. Pawan. It was very comprehensive septic shock, and you have covered many points. So I'll skip those slides. With that, let us start with this patient, 2-year-old, case of diarrhea, vomiting for 2 days, is dull, have sunken eyes, and urine is not passed. So BP machine is not working, and the saturation is 99%. This question is to Dr. Nikhil. How would you manage this patient in your clinic?
So this appears to be a case of acute gastroenteritis, and we have significant volume loss. So there is an evidence of child is dull, the tongue is dry, sunken eyes. So definitely there is some dehydration in this child, and he has not passed urine. So I would proceed with giving fluid boluses to this child, 20 ml per kg by push-pull method.
Okay, so you want to give fluid boluses. Now the question would be, which fluid bolus would you prefer, Dr. Nikhil, normal saline or ringer lactate?
So I would prefer to give normal saline as the initial fluid bolus.
But if you see the WHO chart over here, it does not mention normal saline, it writes ringer lactate. So why the WHO has written ringer lactate and not normal saline?
So there is a recent, it's not recent, it's old. So ringer lactate is considered as better as compared to normal saline, given that the hyperchloremic acidosis is less with ringer lactate as compared to normal saline. And the hyperchloremic acidosis has been thought to be associated with increased bleeding, increased risk of acute kidney injury. And therefore,
so the take-home message is very clear that ringer lactate is preferred. Even in WHO, 20 years back, it is written clearly, use normal saline if ringer lactate is not available. Okay, so you told you will give a bolus. Now, this is to Dr. Satyen. If you're sitting in your hospital, would you follow this fluid like in first 30 ml per kg in 1 hour and then over 30 minutes? Or you would give that 20 ml per kg over 1 hour and then you would reassess after 1 hour? What would you do in your setup?
See, both methods are correct. I don't think that the idea is to give.
Which one do you use?
I generally use 20 ml per kilo because I have been using it since the beginning.
So this question is Dr. Sheikh, sir. Which one do you use, sir? You
See,
follow
I'll tell you one thing.
No, sir. You have to tell one point only, sir.
I'm coming. I will be very straightforward and clear. You know me. Number one, our practice is less is more to begin with. Number two, identify what kind of shock I am in. It is hypotensive shock or normotensive shock. If it's hypotensive shock,
now my question is very simple.
I will give 10 ml per kg. I will give 10 ml per kg. Yeah, I will give 10 ml per kg to begin with. Reassess and 10 ml per kg by push and pull method.
10 ml
and we'll convert this
push
and pull method and convert this, because if you give if you say 20 ml per kg across the age, probably I'm giving more. So 10 ml per kg, fast push and pull, reassess and go ahead.
So this is a case of basically hypovolemia where there is ongoing losses. So you want to give less fluid over here, sir? Just want to clarify.
I never said less fluid. I said 10 ml per kg fast, 10 ml per kg pull and push method, and give as long as your hypotensive shock is converted to normotensive shock. That's all. And then there onwards you go ahead. I never said give less fluid. When you have a shock, you have to first full the tank. Preload
Right.
has to be
So we have
optimized.
20 minutes left. We'll be very short and clear.
Yeah.
Pawan, are you there? Pawan is not there. Okay.
Just
So,
give me a minute. I'm into some urgent thing. I'll be back in 2 minutes. I'm sorry.
so back to you,
No.
Satyen. Why don't you follow this WHO whereas it is being recommended world over?
See, this is generally in an Indian scenario, child come in dehydration and shock. Mostly they are a little malnourished. So giving lot of fluid, they may not be able to handle it at first go. And I'll give 20 ml per kg in half an hour and evaluate. In 1 hour, we generally land up giving.
That is true. That we have understood. But this WHO is for undernourished also. Says WHO guidelines is pan India or pan world. So why are you not giving this 1 hour and 30 minutes and 5 hour and 2.5 hours?
Really, what we see is we reverse. What we are following is that we reverse the shock by giving boluses. We give it in 1 hour or 2 hours, and and then later we give a correction as severe dehydration around 150 ml per kg in 24 hours. Out of that, half we give in 8 hours and half we give in 16 hours. So they are giving the same amount.
So they are giving 100 ml per kg over 1.5 hour in a case of 6 hours, in say 6 hours in infant and over 3 hours in children. Now, I think so. The answer is that basically we are all intensivists. We are sitting bedside. We want to re-monitor them again and again, as opposed to WHO restricted settings. Nurses might be doing it. So it's not bad if you do this WHO also. It's a time-tested maneuver. But if you have intensivist, we follow, as Dr. Sheikh told, we can give 10 ml and reassess, or we can give 20 ml and reassess. Do you do, Dr. Nikhil, sodium, potassium, RBS, and VBG in every severe dehydration? Every severe, not some. I am talking about severe dehydration.
Yes.
Dr. Satyen, do you agree to that, or do you not do anything?
See, when the child comes in shock, the first thing I do is that I will check RBS first and then give the fluid boluses, and then I will take the samples later. First, I have to
If you have a VBG facility, you should do it or not?
Yes, definitely.
If you don't have a VBG facilities, I think so it's a take-home point in severe dehydration. Start having VBG. It's a point of care test. You will get the reports immediately. Next is Dr. Nikhil. We are not able to get a venous access. So how do you manage such patients in acute dehydration, acute gastroenteritis?
If the patient is conscious and is able to take orally, I will go to the oral route and try to give him ORS or nasogastric tube. If I feel that the sensorium of the patient is not good, I would go for an intraosseous line immediately and start giving fluids through the intraosseous line. In case there is a facility of an ultrasound available,
that's it. I will not go details, sir. Satyen,
okay.
Other than dehydration, in what other conditions do you use ORS in your practice?
Just you mentioned dengue. Whenever there is a hypotensive kind of condition, and whether there are fluid loss, it can be a leakage or kind of loss, or there can be a loss in like gastroenteritis or secondary losses like heat stroke, anything, we will give ORS.
So if a patient is in ward having typhoid, you would like to give ORS or you would like to give normal water?
See, if a child is
question
conscious,
is very simple. Patient is in ward stable.
Yeah, so whatever child prefers. If a child prefers normal water, I'll give him normal water also, because he will be eating something also.
Point is clear. It's not necessary you have to give ORS, because ORS can sometimes cause vomiting also.
Maninder, can I come in?
Yes, sir. Sure, sir.
Yeah. See,
the brief comment, sir. We have a lot of
brief. Yeah. What Satyen has said is absolutely right. If the kidney functions are normal, child will accept, body will regulate what is required to be done.
Agree. Very, very clear, sir. So now the same patient. Same patient has 3 scenarios. Severe dehydration, you do a sodium, it has 138. Second patient has 126 and third patient is 160. Dr. Nikhil, how will you manage?
So I would go with my initial calculation of dehydration, which I have done, and continue the fluid according to that in all the 3 cases.
So it's severe dehydration. All 3 cases are severe dehydration. Which fluid would you choose?
So initially after giving the fluid bolus, I will reassess the hydration of the child. So if it's still the child after giving the initial fluid bolus is in severe dehydration, I will calculate it as 10% of fluid deficit, and I will try to correct the 10% fluid deficit over a 24-hour period. And I will add the maintenance fluid to it, and then I will correct the dehydration according to that.
Which maintenance fluid will you add? Which maintenance fluid you will add, sir, in all the 3? Depending on the sodium value, 160, 126, 138.
So I would go for isotonic fluid.
So I want a clear answer. Which maintenance fluid? Name the maintenance fluid.
So maintenance fluid would be DNS.
So you want to give DNS if the sodium is 160, 126 or 138. Irrespective of sodium, your maintenance fluid of choice would be DNS.
Sodium, because this is the initial sodium, I would like to see the trend of sodium.
Correct. So one more thing, sir. Initially, suppose we gave a normal saline bolus of 20 ml per kg and we got a VBG reading, the sodium is 160. The second bolus is the patient is in shock. Would it be of NS or half NS?
No, the bolus has to be of an isotonic fluid only. NS
Correct.
only.
Correct, sir. True. Very true. Message is very clear. Now, this is what we are saying. Initial fluid of choice, irrespective of sodium, is DNS in every patient, because we don't want sudden fall in sodium from 165 to 145. So DNS you have to give. For stool replacement, you can use NS and ORS. And as Dr. Nikhil had told, subsequently after 4 to 6 hours, when you repeat a sodium level, depending on the sodium level, you will define your further fluid. So if the sodium persists to remain above 165, you can shift to half DNS. And after 4 to 6 hours, if the sodium is 170, you can even come to N/4. So the take-home point is repeated sodium measurements in case of hypernatremic dehydration and hyponatremic dehydration is very, very important. Dr. Sheikh, one message from your side. How many times should we repeat sodium in severe dehydration?
Well, depends upon the sodium level. However, we don't do that frequently. That's the point.
So how many times do you do, sir? If the sodium is 165, how many times do you do?
Well, initially I may do 4 hourly 2 times. If the it's at good trending, 4 hourly 2 times, and if it is improving, I will prolong my timing.
Okay, point is very clear. So hypernatremia, you have to repeat your sodium. Now the child is diarrhea and vomiting for 2 days. BP is 90/60, and the child CFT is delayed. Pulses are thready, and the child does not arouse properly when inserting cannula. So is this shock, Dr. Pawan?
Yeah, this is shock.
So, would you say it's hypotensive shock or would you say it's compensated shock?
So can you come again? What's 4 years age? So this is normotensive shock, but the signs of poor perfusion in terms of mentation and motile skin in thready pulses is there. So the child is compensating at the moment, but he's clearly in shock.
So because if you say compensated shock, your fluid will be 10 ml per kg. If you say hypotensive shock, your fluid will be 20 ml per kg. So, so in this patient, what fluid would you want to give? 20 ml per kg or 10 ml per kg?
In this patient,
diarrhea and vomiting, we know it's hypovolemic dehydration.
So this is a clear scenario of fluid loss. I will start with 20 ml per kilo, and I will give it 20 ml per kilo boluses or the aliquots as long as the shock is restored. So 20 ml per kilo, I will choose the bolus.
So shock restoration, as per you, what would be the 3 end organ criteria that we should look for, Dr. Pawan?
So the brain, kidney, and the skin. The mentation should improve with this. Of course, the first intervention will be oxygen supplementation in this patient. and fluid bolus is concomitant. So that should lead to improvement in mentation, improvement in, this patient is lethargic or often dead. That mentation should improve, the mottled skin should improve, the pallor or the mottled skin should improve, and the strength of peripheral pulse, commonly the radial pulse, should be palpably improved. The strength of pulse should be improved. These are, and of course, meanwhile, if you are giving the bolus, if the child sometimes may pass a urine, that would be reassuring.
So this is what Dr. Pawan in this lecture was saying, that in usual ICU definition, the shock is defined on the basis of systolic blood pressure. In a neonate 60, infant 70, more than 10 years, it's 90. And now the question is the cuff bladder size, bladder length and width. What is that? So just to tell you, we sometimes get confused. So figure 1 is right. The length should be covering the 80% and width should be covering the 40%. Of the arm circumference. This is just to give that point. So, Dr. Sheikh sir, how will you define shock? Very simple words.
So define in one word is, demand supply mismatch.
Demand and supply. Perfect, sir. It's a demand and supply mismatch. Now, this was shown by Dr. Pawan. He told, because this is from surviving sepsis. Here it is less than 50 for one systolic BP for 1 year, whereas it was 60 over there, and 1 to 5 it was 70, and so there's a difference in this systolic blood pressure measurement versus this guideline. So why this difference, Dr. Sheikh sir? Why the ICU people want this guideline and the surviving sepsis have gone for this type of guideline?
Well, I think, the guidelines, these kind of guidelines, particularly WHO, is for public health. And public health, public peoples are not, with due respect, are not intensivist. So they have low threshold for early identification. So probably that is the reason that, they have made low blood pressure for that.
Not earnest, it is late identification. Systolic BP less than 50. We
That
are diagnosing early. We are saying at less than 60, 70, sorry. So we are diagnosing early in ICU. They are diagnosing late.
Yeah. So I honestly, I don't have the answer. Anybody can take up this answer.
So I think it was because the surviving sepsis campaign mainly mentioned about giving less fluids. So the main focus in this particular campaign was in giving less fluids. So, but this also clearly mentions that there is an or here. So the cold extremities, prolonged capillary refill more than 3 seconds, and weak or fast pulse is also a criteria for deciding.
So
this
what
should not
the
be
surviving sepsis is saying, that it's okay not to label them as hypotensive shock, because once you label hypotensive shock, you'll give that 20 ml per kg, and surviving sepsis says that fluid once given in is difficult to come out. So they don't want you to give multiple fluid challenges. So this is what we are discussing, the uptake and the delivery. So what we focus is increasing the oxygen, hemoglobin, cardiac output, but we have to focus on the tissue demand, decreasing tissue demand also. Now this 4-year-old has a BP of 88/60, same patient. Now the question was 20 ml, 10 ml or 5 ml. Dr. Pawan was clear, because this is hypovolemic shock, I want to give 20 ml. Dr. Satyen, Gyani, do you agree to that statement? You're muted.
Somebody unmute Satyen. He's not able to do it.
एक्चुअली मैं डिस्कनेक्ट हो गया था. हाँ, क्या पूछ रहे हैं?
डिस्कनेक्ट नहीं हो गए थे, तुम हमारी बैकग्राउंड, तुम चांद में पहुंच गए हो, तुमने मोबाइल चेंज कर लिया.
पता नहीं तो वो मोबाइल, वो लैपटॉप बंद हो गया तो मोबाइल से आ गया मैं.
ठीक है. So, Dr. Nikhil, do you agree to 20 ml per kg or 10 ml per kg in a hypovolemic shock? Dr. Nikhil.
So I will give 10 ml per kg, see for response, and then give another 10 ml per kg.
So Dr. Sheikh sir, there's a discrepancy. Dr. Pawan told it is clearly hypovolemic fluid is at loss, so I want to give 20 ml, whereas Dr. Nikhil, another intensivist, says 10 ml. So what is your take-home point from this?
If you see the guidelines clearly said 10 to 20 ml per kg.
Yes.
10 to 20. So, okay. So the second question is, over how much time would you like to give bolus? Sheikh sir.
Okay, fine. It's very clear. If you have hypotensive shock, there is no timeline. You have to just push and pull. So you have to push and pull. bring from hypotensive to normotensive. Once you bring the normotensive or normotensive shock, you have some time. You can give over 15 to 20, as much as 30 minutes also. That's a timeline.
So now the patient has a blood sugar of 40 before giving a bolus. So Dr. Satyen, would you give a bolus of dextrose first or saline first?
If I can give both simultaneously, I will give dextrose very fast and give bolus
Yes.
over half an hour.
So you want to give dextrose first, followed by saline. It's a very clear message. What about DNS, Dr. Satyen? Would you give DNS? Because they say dextrose भी है
No,
इसमें
no, no,
saline
no.
भी है.
No, DNS is not used for correcting hypoglycemia. It's a maintenance fluid for
And
hypoglycemia. When there is hypoglycemia,
yes.
I will give dextrose, and bolus के लिए saline, I will give only saline.
And
DNS
Maninder,
can't
DNS is
substitute.
never DNS is never the fluid of for boluses.
Resuscitation. Yeah.
Bolus.
Yeah, resuscitation.
It won't correct hypoglycemia also.
Yes.
True. So now this is just to say that in the back of the cannula, you will find these markings that the pink cannula, the maximum flow rate is 54 and the yellow cannula is 13 ml per minute. If you see according to the weight of the child, for 10 kg, the yellow cannula is okay, for 20 kg blue, and for 40 kg pink is recommended, so that you can give adequate amount of fluids in those 15 minutes. So now we have this patient with high grade fever, for 2 days, now is drowsy, and we see the BP is low for the age, child is drowsy and brisk CFT. What is your diagnosis, Dr. Pawan?
This is clearly hypotensive shock. So this patient is in shock, wherein you have this hypotension. You can see the age is 16 years. We don't expect anything less than 90. And this also he is on room air, not maintaining saturations, and there are poor perfusion of the brain as he's drowsy. However, his capillary refill is there's flash capillary refill and there are bounding distal pulses. So this is clearly a shock with hyperdynamic state.
So septic shock, is it right?
Septic shock.
Septic shock.
Yeah.
Okay. So now there's a word of warm and cold shock. Dr. Nikhil, do you use in your practice, or do you feel it's obsolete? Your personal experience versus evidence.
Personally, I do use it in my practice. So, but if you go by guideline, these words are now obsolete, and a single
Obsolete.
patient can actually fluctuate between warm shock and cold shock.
So warm shock earlier was defined as bounding pulses with low diastolic blood pressure, wide pulse pressure, and hypotension. And cold is basically narrow pulse pressure, hypotension. So in your daily practice, Dr. Satyen, do you use this definition or you don't use this definition?
Generally, see, when we have a advanced cardiac monitoring, then we go
No,
for
no,
the
no.
arterial
In
line.
your practice, what do you use? Yes or no?
No, generally we classify warm or cold after having an arterial line.
So you will wait for an arterial line to decide whether the patient is in warm or cold. You will decide after arterial line your vasopressors.
No, generally we start the vasopressor.
So
Our
on
first
what
line is
basis would you
norepinephrine.
start norepi versus epinephrine? On what basis will you start?
See, if the child is having good pulses and I'm seeing that the
That's what you are going to say.
pressure is,
Ultimately, warm shock and cold shock. On that basis, only you are starting your vasopressor. Then you are saying, I'm
yeah,
going
yeah.
to arterial line.
My first step will be like that only. If the peripheries are cold, I start with epinephrine, and if the peripheries are warm, I start with norepinephrine. But
So
at that time, I'm not firm with this classification, and as soon as I get the arterial line, I can change my decision.
So the take-home point is very clear. In the beginning, you can use this, but if you have an arterial line, definitely believe the arterial line more than this parameter, because sometimes it can mismatch. It might not match. Dr. Sheikh, one word on this.
I agree with you. These are clinical parameters, but to be taken with caution.
So this is what we were telling. You will usually increase these things for shock, but control the tissue demand by decreasing fever, agitation, and sometimes intubating a patient. This is already discussed, so we'll just skip it. We'll not go into it. But problem is how much fluid to give, whether to surf on it or whether you will sink. So this was a study which told give multiple fluid challenges, target. And then this study from Africa claimed that if you give uncontrolled fluid challenges, then it actually causes deaths, mortality, and world over, the world has shifted, including PALS guideline have shifted. Many studies, this is repeated, that do not uncontrolled fluid challenges. The nice waterfall can become a bad flood, and your patient will go into cerebral edema, pulmonary effusion, cardiac failure. This is very, very bad. So, Dr. Sheikh, sir, in one word, how do you decide in the beginning? Because the child has come from another hospital, how to give fluid? You don't have an ultrasound with you, sir. How will you do it?
Maninder, there is no one word. So if you want, I need to explain it properly. I am observing every question you are saying one word.
Sir, take 2 minutes, sir.
We'll give one word.
So
Can I come in, Maninder?
So,
Preload
sir,
assessment.
so I'm trying to give in one word, but it is becoming every time
Dr.
complete in one word.
Dr.
Yeah.
Maninder,
Yeah.
we have enough time, so don't worry about the time. So
Okay.
your discussion is going very well, so we are enjoying also.
Because, if you
Everybody
need
is
to
enjoying.
understand people, you cannot hit and run. You have to make people. Yeah, it's not hit and run.
So, sir,
if
you don't have
want
an ultrasound machine.
I don't have one word.
So how will you decide, sir?
So what is the question? When do you decide to be careful in the beginning? Only as I said, nowadays the things like less and more. Less is more. So I will go slow based on the clinical scenario. As I have been saying, if it is a hypovolemic shock, I will be very fast. Once I optimize, I will go slow based on the intervention, based on the reassessment.
But in the reference slip,
Maninder, can I come in?
Yeah,
For your question, one word. So one word is preload assessment.
So how do you do preload?
How many times you can do preload assessment in the clinic, in the OPD on the ICU?
So you just look at the liver, your baseline thing, look at the Krebs, and number 3, look at the jugular pulse. That will tell you whether you can go wrong. If there is a concomitant myocardial depression in this possible septic shock, then the JVP will be there. It will tell you that, hold on, be little less generous with your boluses and start with small inputs, 10 ml per kilo. And after first 10 ml per kilo, reassess with hepatomegaly, auscultate the patient, and again look at the jugular venous pressure. And if your unit has portable X-ray, just get the X-ray. That will also give you, because Maninder has already told you don't have ultrasound machine. I mean, to the person who's responding.
Correct. So there's a classical teaching.
Can I say one thing?
Points. Yes, sir.
What I do is, in a scenario where I don't know the preload status, and suppose it's a small child, I cannot see the JVP, the liver is also somewhere 2 to 3 centimeter, and you are unsure what it is, I give a small fluid bolus and look at the hemodynamic changes with that bolus.
Yes.
Usually that gives me the answer. 5 ml per kg fluid bolus.
So Dr. Nikhil, over to you only. If I give a 5 ml per kg, there are 3 scenarios. Either the patient will improve and you know I will give more fluid, or the patient will not improve. If the patient does not improve, that means there are 2 reasons. Either you have not given adequate fluid or the heart is failing. How do you decide that?
So, sir, I will tell you what I do. Okay. So when you are giving fluid, you will see the heart rate coming down on the monitor.
That is scenario 1. That is over. Now I'm saying
if the heart rate is not at all fluctuating on the monitor, when I am giving my fluid bolus, if there is no fluctuation at all in the heart rate, or if the heart rate is rising, I will not give further fluid boluses, and I will try to look other parameters for assessing my preload. The
point is very clear. Clinical skills over here in a sick child can sometimes fool a clinician. So be very careful. Do not just believe on the clinical parameters in a sick child. You need to sometimes use heavy equipment. That is why PICUs are made, and that is why referral happens.
So Maninder, what we do, I share that, you just in such cases we give 10 ml per kg, reassess the response, whether it is fluid responsive or not, and then go ahead clinically. So first thing, we must admit that we have to go more clinical than gadgets. Ultimately, clinical is the one which gives better. Of course, the gadget do help, but clinical is equally important. We cannot undo clinical.
So what Dr. Nikhil was saying, giving a mini fluid bolus, that is 5 ml per kg, and Dr. Sheikh is giving 10 ml per kg. Now the advantage of 10 ml per kg is it will push a child. Either the patient will become into CCF, you will know, or 10 ml per kg patient will actually improve. So I personally feel generalized statement of 10 ml per kg for every type of shock is okay if you cannot generalize, if you cannot
Yes,
specify
yes.
it or personalize it.
No
The point is,
generalization. Every case is different. Yeah, every case is different.
so
No
two policies
generalization.
are given on norepinephrine, child's BP is still low. The same scenario, Dr. Satyen, would you intubate this patient or would you hike up the inotrope or would you add one more inotrope and then you will intubate? How will you decide when to intubate? Two inotropes maximum dose, one inotrope maximum dose?
See, the child is 80 is on 86% on room air. I will make some preparation for the intubation. I'll start oxygen. He's started getting drowsy. So I have to somewhere in some time, I have to secure the airway also. I have to control the breathing also. So, and I have to decrease the work of breathing also. So I will be doing both the things simultaneously. I will be managing BP also,
No,
apply some
Dr. Satyen,
oxygen.
give me a clear answer. When will you intubate this child? The child is already on norepinephrine at 0.1 mic per kg
Yeah.
per minute. When will you intubate?
So
I will increase. I'll first at this point I will give some oxygen. I'll increase the norepinephrine and I'll wait for 15-20 minutes. एकदम
Okay,
अभी intubate
norepinephrine
करने
till
की.
what level will you intubate?
See, if the child is getting further drowsy, his work of breathing is increasing, I will intubate immediately.
Yes, yes. I agree with
It
Satyen.
does not depend on norepinephrine.
Yes.
It does not depend on norepinephrine, but if there is not much work of breathing, if sensorium is improving, I will wait. Lungs are clear, there is no murmur,
No.
there is
My
not
question
respiratory
is,
rate is 50%.
child is on norepinephrine 0.1. Would you wait for epinephrine to
Yeah.
be started and then intubate or any criteria? Dr. Nikhil, what is your practice?
Generally, in
take
shock,
clear
I
information.
will start norepinephrine first because after intubation, the child may further worsen.
Okay, that is okay. Now, the point is intubating. At what point you would like to intubate, Dr. Nikhil?
Sir, I will
At
intubate
this
this.
point,
I will prepare my staff for a CPR scenario. I will tell
Yes.
everyone we may enter into a cardiac arrest scenario. I will give a small dose of ketamine 1 mg per kg and try to intubate.
Okay, that is okay. That is okay. My question to Dr. Pawan is, will you intubate this or wait?
I will intubate this patient, the reason being two, that fluid resuscitation and vasoactive drug, namely norepinephrine, which was fitting in the clinical scenario, did not lead to improvement. So it's straightforward that I have to offload the heart because the muscles are taking too much of blood supply. We need to intubate this patient. Yes, I will intubate.
Okay. So during intubation, Dr. Sheikh, sir, any precautions we have to take? Because as Dr. Nikhil told, he will crash.
See, this is physiologically challenged intubation. So we have to take everything into account, including the, as Nikhil has said, and try to optimize the blood pressure, have the preload optimized, and give the vasoactive or minimize the vasoactive, minimize the medication which causes the your sympathetic dry offloading. So those taking care of those precautions, we will intubate the child.
So any bad experience while intubating, did you lose any child, Dr. Sheikh, sir?
Yeah, we have all kinds of experience, and experiences defines of years of mistake. So we have all kinds of experience.
So intubation should be done with lot of preparation.
Lot of
Keep a
preparations
backup.
Yes.
Plan A, Plan B, Plan C. Keep them ready.
Everything.
Don't take it easily, as Dr. Satyen told. It's not an easy decision. You have to be doing it very carefully. You have decided to intubate, then do it in a very controlled fashion.
Controlled. Yeah, it has to be done.
So there are many fluids in the market: ringer lactate, gelatin, starch. Which fluid would you choose in pediatric sepsis, as Dr. Pawan has told? Which one do you use, Dr. Pawan, in pediatric sepsis, and why?
I use ringer lactate. So ringer lactate is easily available, inexpensive, and is consistent with the current guidelines. And over last I think 3 to more than 4 years, we have almost given away with any other fluid, except by and large our default fluid in for the bolusing ringer lactate, and for maintenance ringer lactate with 5% dextrose has practically become a norm for us, and it has bring down a lot of complications low. So this in particular scenario of septic shock, I will do boluses, fluid boluses with ringer lactate. It's a balanced crystallography.
So Sheikh sir, Dr. Pawan is saying you will use ringer lactate for septic shock. WHO is saying use ringer lactate. Why in India there is a scare of using ringer lactate?
I think there's a, people do think the ringer contains the potassium 5 mg per liter. So that, and then you may have some kidney injury also. So people are worried that, this in the presence of kidney injury, using the fluid containing potassium will be having problem. But this 5 mg per liter potassium definitely will not cause much harm. You can very well give the ringer lactate as a resuscitative fluid.
And there is one more thing, lactate in shock. Do you want to give lactate in shock? People don't use it in shock, but Dr. Pawan is saying I'll give lactate only in shock.
Okay.
This lactate in the liver gets converted acetate, so you can very well use it. There's nothing the problem.
So, but this lactate, if the liver is okay, then convert into bicarb and it's fine. Perfect.
You can.
But if there is liver failure, then we should not use ringer lactate.
Correct.
Yes, that you have to be careful. And even in the you cannot continue with the ringer lactate when you have advanced kidney injury. And the initial is okay, but advanced you have to be careful.
The point taken. Dr. Satyen, Gyani, is there anything normal in normal saline? Anything normal in normal saline?
There is nothing normal in normal saline. It has more of sodium. Everything is high.
Non-physiological.
So even the pH, if you see, it is very low. It's quite acidic.
Very low. Yeah.
And
Acidic.
high chloride. It is not a normal fluid. It's not a normal fluid. We should be away from normal saline. And everybody is talking about balanced crystalloids, plasma light, which is quite expensive as compared to ringer lactate. Then about this starches, colloids, basically they should be avoided because they cause kidney injuries and coagulopathy. If required, albumin is quite safe. Now this patient is there, again in septic shock, but has not passed urine since 8 hours, and creatinine is 2. Heart is functioning okay. He is on oxygen. Now BP is low. So no urine, that means patient is underdepleted or kidney has stopped functioning. So Sheikh sir,
इंटूबेट तो अभी तक नहीं किया है इसको.
इंटूबेट नहीं किया हमने.
रूम एयर पे छोड़ा है.
नहीं, on 10 liters पे रखा है. 10 liters में 98 है.
Okay, good.
So Dr. Satyen, what would you do in this patient? Now there is AKI. This AKI can be because this preload is less, maybe hypovolemic. Or do you think the kidney is shut down and no urine? If you give a fluid challenge, it will cause lung edema. What will you do in your scenario? You will give fluid challenge, furosemide challenge, or fluid restriction?
Now I have an ultrasound machine कि अभी भी नहीं है.
नहीं है.
अभी भी नहीं है. ठीक है. Then see, the first thing still abhi is only few hours have been passed. So now I will more focus on increasing the blood pressure. Somehow I have to increase the blood pressure and improve the kidney perfusion, and I'll evaluate for it.
You will increase the blood pressure by giving fluid, or you will increase the blood pressure by giving inotropes.
See, still he has some oxygen requirement. I am little wary that there may be some ARDS coming up. Fluid may be leaking in there, so I will be very cautiously. I may give one more bolus at this time.
So this is the point we wanted. So you will give a mini fluid bolus. Would you give a furosemide because no urine has happened?
No way. On hypotension, I don't give furosemide.
No way.
So when do you give furosemide, Dr. Satyen?
See, if the perfusion is okay, my all targets of my shock have been attained, and child is out of shock and is not passing urine, then I may give a trial of furosemide, and if it is not working, then I will shift to renal support therapy.
The replacement therapy. Yeah.
Perfect. It looks perfect. Well, very nice. Because if you keep on giving multiple fluid challenges, however small it might be, but multiple challenges ultimately will make the lung white. The fluid is going somewhere if it is not coming out in the urine. So be aware of this fill and spill effect.
It is very easy to give fluid, but it is very difficult to take it out.
Maninder, one important point is very Satyen has said, no furosemide if blood pressure is not normal. If blood pressure is low, no furosemide.
Agreed.
No,
yeah. So everybody is saying that they use DNS in all their ward patients. What do you do, Satyen, in your hospital?
See, we use DNS only, and if we see that थोड़ा सा एसिडोसिस हो रहा है, we shift to half DNS.
Dr. Pawan, do you use DNS or half DNS?
Not at all. Neither of the two. I only use RL with 2 ampule dextrose, 50%, meaning RL 5% dextrose.
Perfect. Dr. Nikhil, what do you use maintenance fluid?
So DNS.
DNS. Sheikh sir, there's a lot of scare among pediatricians that if you give DNS, it will cause hyperchloremia, and because it's maintenance and the kidney will shut down. What to do, sir?
Not at
And they
all, as long as your
choose half
kidneys are
DNS.
normal. Not at all, as long as your kidneys are normal, kidney will take care of fluid, kidney will take care of your electrolytes. Number one. That's number one. Number two, the important is message is that isolate P should be discarded from our everything. I mean, it should not be the part of your fluid therapy in children.
So which fluid do you use, Sheikh sir, in your wards?
Well, we in our hospital we have a good setup like nephro post-op transplant patients and all. So our strategy is like this. We tend to avoid DNS in patients of the cardiac patients and the renal patients. So because the high sodium may fluid retention will be there. So we
Leave the
tend
cardiac and
to
nephro,
give half DNS in those.
other patients.
Other patients we tend to give DNS. Otherwise, we give half DNS in this situation.
Perfect. So message is very clear. Now we have this diagram, Sheikh sir, which says within 15 minutes you give this 20 ml per kg, 2017 guideline, 20 ml, 20 ml,
Yes.
20 ml up to 60 ml, and this
Yes.
defined fluid refractory within 15 minutes.
Yes.
Dr. Pawan, they defined this septic shock guidelines 2017 and before, they all defined fluid refractory that you have to give 20 ml boluses. But now in the latest guideline, you have told they are defining it up to 30 minutes or even up to 1 hour.
Yes.
Correct. So this is one change that we have seen over here, that the guidelines now say less of fluid, even if you have an ICU setup, give less of fluid.
Yes.
Then
And
another
particularly
thing,
that after that, Maninder, after that fees trial that we have been talking all along.
correct. So now they are saying within 15 minutes start epinephrine. So surviving
Yes.
sepsis, the latest one says you can even start before 15 minutes. It is not necessary that you have to give 3 boluses and then start. You can even start before if you think the patient is not going to improve. Now, one more thing is here, it was written for all shocks epinephrine first. Dr. Sheikh, what is your take on that?
Well, there's no head-to-head evidence which should be started. Either can be started. In our unit, we tend to start all patients except cardiac norepinephrine, cardiac epinephrine.
Dr. Satyen, in all your patients in ICU, if the patient want to be started on a vasoactive agent, which agent you will start first?
I start with norepinephrine mostly. Mostly I start with norepinephrine.
Dr. Nikhil.
Norepinephrine in septic shock.
Okay. So everybody says that you're moving away from epinephrine and they're preferring to use norepinephrine. And this is what the late. So this is also what the latest guidelines people are now proposing, that consider norepinephrine along with the fluid bolus also. You can consider it. Not necessary that you have to wait for 2 challenges, but fluids to be controlled. Vasoactive agents can be given through peripheral lines, and dopamine is almost dead in PICU, but very much alive in NICU. So be very careful. Okay. So now this is one more child. The heart rate of 200, not feeding well. Cold extremities, crackles, hepatomegaly noticed. We all know that it looks like a cardiogenic shock. Some people might say it's bronchiolitis. What are your management plans, Sheikh sir?
Well, again, if it is hypotensive shock, mini bolus, number one. Number two, if your epinephrine, the first vasectomy will be epinephrine this particular child. Small fluid bolus followed by epinephrine, and if I have a blood pressure which is optimal, I will start after reducing agent. And if even of all these things, the patient is like not responding, I may go for early support, respiratory support, NIV versus invasive ventilation.
So this, sir, sometimes people use HFNC and some people use CPAP. You're suspecting cardiogenic shock. Which one would you prefer, sir?
Well, when we say ventilation, it has to be pressure. CPAP is the ventilation, NIV is high flow, your HFNC is without pressure. So subject to availability, you can give. We are giving HFNC.
So
HFNC
usually
followed by
cardiogenic, you need some amount of pressure, so CPAP would be better.
Yeah.
If it is bronchiolitis, then
pressures are
HFNC
always
would be
better. Yeah, pressures are all, as I said, ventilation means pressure.
Because in cardiogenic shock, if you give some pressure, it will be like an inotrope only.
Yes,
Yes.
it's, I don't know. It is the
Afterload reduction.
afterload reducing agent. Yeah.
So we have this patient of DKA, Dr. Satyen. The blood sugar is 590. What will be the first fluid bolus and over how much time will you give it?
Child is in shock. So first fluid bolus will be normal saline. And I'll
So
give it in slowly, a little bit slowly. I'll give it over 1 hour, 20 ml per kilo.
20 ml per kg or 1 hour. Dr. Nikhil?
So, sir, the glucose is high. I would like to look at the blood gas and see.
That's direct answer. We know it's severe DKA. In
Okay,
shock.
with severe decay. So if the pH is less than 7.1, I would give a 20 ml per kg fluid bolus over 30 minutes.
Suppose sir, ABG machine is not there. This patient is there with a blood sugar of 590 in RBS. Would you wait for a VBG or would you treat it?
I will treat it.
So my question is 20 ml per kg versus 10 ml per kg or 1 hour. What fluid amount will you use?
Sir, I would give a first a 10 ml per kg fluid bolus over say
So
20
Dr.
to 30
Satyen told 20, you are telling 10. Dr. Pawan. Dr. Pawan?
Yeah. So I would go with 20 ml per kilo over the first hour.
Okay. Dr. Sheikh, sir.
I will go 10 ml per kg.
So we have a discrepancy. Dr. Sheikh, sir, how would you address it now?
Well, I think, as we say, less is more. That's the ICU. As long as the patient is not in hypotension, we can small bowl 10 ml per kg is sufficient, and then you can go for the maintenance fluid in this particular case as a SPAT guideline.
So they are saying guideline says only if the patient is in shock, you give 20 ml per kg.
20
Otherwise, 10 ml per kg is sufficient for 1 hour.
Yes.
And the fluid of choice will be your normal saline. And thereafter, if the sugar is falling, you can convert into DNS or half NS as per the scenario. The take-home point is Milwaukee protocol is dead. Start using SPAT protocol. That is the take-home point. Now, this is for all the audience. In 1 liter bag of sodium chloride, how much salt is there? Or how many bags of Lay's chip you would need to have to match the salt content of 1 liter normal saline? So you would have to eat not 5. You would have to eat 12 bags of saline chips. So much salt is there. Just imagine, and you give saline just rapidly. Be very careful. Yes. Saline has a lot of chloride. It is very dangerous. Be very careful. We've already discussed dengue shock syndrome. About maintenance plus 5%. Dr. Nikhil, in ward patients, I've already discussed. Can we use this maintenance plus 5% in ICU also?
Yes, we can.
So basically the difference is 48 hours in ward, and over here you can give the fluid in 24 hours. 24 hours, it will come 5 ml per kg. In 48 hours, it will come 3 ml per kg per hour. And this is the upper limit. That's what we are trying to say. Dr. Pawan, meningitis child, what IV fluid would you start? And would you, at what rate? Maintenance fluid. Dr. Pawan is...
So, admitted, what rate would you consider 75%? So, in a proven meningitis, I will not, until I have not proven SIADH, I'll go with the full maintenance fluid. For me, the key point in this meningitis patient is preserving perfusion. So I will, so I think the second line, what rate would you consider? 75% is
of the total maintenance.
Okay, so you are mentioning restriction to 75% maintenance there.
And that, would you do that or for a patient in ward, or would you give full maintenance?
If the patient is not taking orally, I will go with full maintenance.
Okay. Satyen, Gyani, what would you do? IV fluid in ward patient in meningitis, not in shock, but not taking orally. You'll give full maintenance
what we
fluid or you'll
follow,
give 75%.
we give full maintenance.
Dr. Nikhil, patient is not in shock.
Do we have electrolytes?
Yes.
Electrolytes are normal.
Electrolytes
It's
are
the
normal.
rate of the fluid we are talking about. I'm not talking about the type of fluid, the rate of fluid.
Full maintenance.
Dr. Sheikh, sir, would you like to give 75% in a patient not in
No,
shock?
no, I will give full maintenance. There is no need to cut short in this.
So why this 75% has come and why people follow this 75% when all four of you do not want to give this?
So there's a concept of SIADH. I think that concept of SIADH is responsible for this concept of 70%. So we consider that all patients who have got some respiratory illness or who have got meningitis have got an underlying SIADH. So in all patients who are having SIADH, we need to restrict fluids because we have an underlying hyponatremia. Because the basic treatment of SIADH is fluid restriction.
But Nikhil, in the Maninder, in the beginning we don't know all these things. In the beginning we can start the full maintenance, and thereafter we can titrate the
According to
volume and
situation.
the type of volume of the fluid. In the beginning we can start the full maintenance because
So there, if there is ICP, suspected ICP, would you like to restrict fluids then?
exactly. Huh?
Yes, yes.
No. Even in
Yes.
raised
No,
ICP.
no restriction in the ICP because your
No,
fluid is your therapy is CPP directed therapy.
Yes,
So
perfusion.
CPP directed therapy, sir, you want to give fluids because the body
No,
would be trying
I
to
want to
give
optimize my preload. I want to optimize my preload. Even in there, we have to optimize my preload.
So my question again, sir, if the patient is not having any vomiting, dehydration or shock in ICP, would you want to give full maintenance?
We will give full maintenance. There's no harm in giving full maintenance. As long as
Dr.
the
Pawan, patient is not in shock, patient has a good pulse volume, not in dehydration, patient has such features of raised ICP. Would you like to restrict fluids?
No, not at all. If there are
Not at
features
all.
of raised ICP, all the more you need to optimize the
Fluid.
fluid to improve the
Yes.
cerebral perfusion.
Yeah.
Dr. Satyen, Gyani, what is your take on that? Would you like to restrict fluids?
If the preload is optimized, I will like to restrict my fluids. I will not give maintenance fluids at this time because this child may worsen any time. He may develop some other complications also.
Dr.
CPP is
Nikhil, what
maintained.
would you like to do?
If CPP is maintained, then I'll like to control my fluids.
CPP is maintained. There's no dehydration, no shock. CPP is
Then
maintained.
it's okay.
Would you like to restrict fluids, Dr. Nikhil?
But actually, it is. So what you are trying to say, you're trying to say both the things, that the child is having a raised ICP and there are no features clinically of the raised ICP. So
does it mean that every raised ICP will be in shock?
no, not shock. But
No,
the child
independent of the shock,
vomiting,
Maninder, independent of the shock, in the raised ICP, you have to have the adequate preload. And you
Sir,
cannot.
if the body is functioning well, it has a compensatory mechanism. It will raise the blood pressure. Would your
No,
additional
Maninder,
fluid raise the
if
blood
you say
pressure
restrict
further?
the fluid, if you say the restrict the fluid in the ICP, we are giving the wrong message. It's very clear. It is the teaching of past, not present.
Okay, if the child has new onset drowsiness, so the child has thrown a seizure and new onset drowsiness, what will you do, Sheikh, sir? Would you give saline bolus, 3% saline
If
or
there is
mannitol?
alteration in sensorium, of course, we have to take care of that. 3% osmotherapy. Whether it is 3% or mannitol, whatever is available, we give 3% saline.
Dr. Nikhil, sir is saying he gives 3%. What do you give in a patient?
3%.
Dr. Pawan, which one do you use, mannitol or 3% saline?
3%.
And Dr. Satyen?
3%.
So in which condition will you give mannitol? Everybody is saying 3%. So when will you give mannitol, Dr. Pawan?
So usually, I don't have anything. See, if you go by the evidence, there is no, like they say, it's a sort of equipoise. Both mannitol and 3% saline have a way there. But usually,
if it is so equivalent,
after,
if it is so equipoise, then why every four of you are saying 3%? Why everybody is removed away from mannitol?
Because there's a risk
we
of
do not want the perfusion to get compromised. One thing is, we are clear that even with raised ICP, the key determinant is perfusion of the brain for the outcome. But the second thing is, you also have to achieve the reduction in ICP, and 3% will do it without creating a relative hypovolemia in the intravascular compartment.
So mannitol, is it dead in ICP, Dr. Sheikh?
Not at all. It does not mean if you have 3% saline. Suppose you have you don't have 3% saline in unit,
But
and
you're
you have
not using
mannitol.
mannitol, and so I'm asking which condition you will use mannitol. You're not answering, sir. Which condition will you use mannitol? I have both.
I will use 3% saline if I
That
have.
means
If I have
mannitol is dead. That means
no,
mannitol is
not dead, not dead. You can give mannitol if you don't have 3% saline. That is my answer.
No, but I have both. I have both.
So,
See, Pawan has answer for that. It causes relative hypovolemia, especially in the patient who have compromised perfusion. Mannitol is not to be given. So, 3% saline is safe, relatively better with regard to perfusion maintenance compared to mannitol. So that's why people are going for 3% saline.
So it's not that mannitol can cause it, but if there's an underlying AKI or there's an underlying shock, avoid mannitol. Otherwise, you can use either.
okay.
Yeah, that's what.
Okay, so fluid in trauma, basically you give lots of fluid, but if there's blood loss, you have to give PRBC, FFP, and platelets. And in ARDS patient, Dr. Sheikh, sir, how do you manage?
Well, in the ARDS, fluid restrictive therapy, in one word.
Fluid restrictive. Okay, so we will over here, sir, 75%.
Fluid restrictive, it's not percent. You can go up to 60%, 50% as long as your hemodynamics are optimized.
So you want to create a negative balance.
Yes.
Create a negative balance. Okay. So so what we are ending it, that fluids in pediatrics, we can all drown in it. So be very careful. Now I'd like one word take home message from each panelist, because I didn't share the slides with them. So it was a very extempore presentation. So one line from, first of all, the senior most.
Maninder, can we take some of the points in the chat box, because those are the important things I was looking at.
Sir.
So you can just have a word and we can clarify that also.
Okay, so the question to Sheikh, sir, can DNS be given as maintenance fluid in IC bleed?
Yes, we can give. What is there? As long as there is no hyperglycemia, we can give.
So I think so. The question would be, if there is an intracranial bleed, would you give mannitol?
With caution.
Because this mannitol can seep into the bleed, and it can absorb the fluid, and the IC bleed can worsen. So if there's an IC bleed, again the fluid of choice would be your 3% and not
3% saline. Yeah, but then again, Maninder, if you don't have 3% saline and you have mannitol, you can use mannitol there also.
So can plasmalite be given as maintenance fluid? So dextrose containing plasmalite is there. You can use that as maintenance fluid, and that is what is recommended in septic shock guidelines also. Shock is uncommon, raised hypertension.
No, I think this point we need to understand. It is not that shock is not common in raised ICP. It's very important to have the proper hemodynamics optimization. It's not always shock. It's, in fact, they say you have to maintain the map of around 58% in patients with raised ICP, or not in the raised ICP, any patient with CNS pathology, independent whether you are document raised ICP or no raised ICP.
Correct. So basically, CPP is your map minus ICP. So if ICP has gone by 10 up, then your map also should go by 10 up.
Go by 10.
How so you increase the map, fluid or inotrope is up to you.
Inotrope, yes. The message is like this. So we don't want shock to occur in patients of ICP and then treat. No. Optimum hemodynamics is the key to the ICP management.
Plasmalite A can be used in resuscitation. Definitely, it can be used. It is just expensive. Okay. What is a resuscitation fluid in liver failure? Not ringer lactate. You can use any other fluid other than ringer lactate. Correct. That everybody has answered. Septic shock. Can we continue DNS as maintenance fluid in correction of hypernatremic dehydration? I think Dr. Nikhil already told that. On repeated sodium, if the sodium is rising, then you can shift to half DNS. Otherwise, the first fluid of choice is always DNS, irrespective of sodium level.
Yes.
So now let's take one take home message.
Someone has
Dr.
asked that question of maximum dose of inotrope before moving on to the next inotrope. Can we answer that question?
So where is this question? So what the question is that would you go for maximum dose of one inotrope or would you add another inotrope in between? Dr. Nikhil, would you like to answer?
Yeah, so so it will depend upon the hemodynamics. So there's nothing like going to a maximum dose of one inotrope and then adding another inotrope. So it will depend upon the hemodynamic situation. There is a possibility that in one patient you can add the patient is already on 0.1 of epinephrine and you consider adding 0.05 of norepinephrine. There can be another patient in which the patient is on 0.1 of epinephrine and you increase the epinephrine first before thinking about norepinephrine. So it depends upon the patient, the hemodynamic status, what your focus is saying. Based on that,
बेसिकली ये था कि पहले सब बोलते थे डोपामीन स्टार्ट करो 10 पे पहुंच जाए फिर डोबुटामीन ऐड कर दो. ये क्लासिकल टीचिंग थी, ये ऑब्सोलीट हो गई है. अभी डिपेंडिंग ऑन द क्लिनिकल सिनेरियो, अगर आपका वेजो डायलेटरी शॉक है, एसवीआर उड़ा हुआ है, डायस्टोलिक ब्लड प्रेशर नहीं है, नॉरेपी दोगे. अगर आपको लगता है कार्डियोजेनिक कंपोनेंट है तो एपिनेफ्रिन दोगे. एंड इट कैन बी मिक्स एंड मैच, so you can adjust accordingly and do not wait for maximum dose of one inotrope to start others.
Exactly. I think that the last point is very important. There is nothing like go to maximum and go to next. It's absolutely clinical judgment at the bedside. Because shock is not one. It is not cold shock for 24 hours and warm shock in the next 24 hours. It's a minute to minute, hour to hour change in the scenario.
Correct. Pawan, Dr. Pawan, any take-home message? One-liner?
One-line take-home message is fearlessly give maintenance fluid ringer lactate with 5% glucose in your wards. Refer your Nelson textbook of pediatrics.
बहुत बढ़िया सर, एकदम परफेक्ट टेक होम मैसेज. डॉक्टर सत्यन, ऐसा ही जोरदार एक मैसेज और.
Never use isotonic fluids, isolite P, etc. kind of thing.
Isolite P is out, P is poison.
NS use कर लो RL की जगह, but वो मत करना.
Perfect, एकदम. डॉक्टर निखिल, you have a tough point. एकदम इससे भी जबरदस्त जोरदार मैसेज.
सर मेरा मैसेज हमेशा एक ही रहता है, मॉनिटर करो पेशेंट को, मॉनिटर एंड देन डिसाइड. एक इंटरवेंशन कोई भी गोल्ड स्टैंडर्ड नहीं होता है. इन एवरी पेशेंट थिंग्स आर डायनामिक. सो यू डू, देयर इज नथिंग लाइक इन वन पेशेंट पहले एनएस देना है या पहले डीएनएस देना है या पहले आरएल देना है. आप जो भी इंटरवेंशन कर रहे हो उसका पेशेंट पे क्या रिजल्ट आ रहा है, प्लीज लुक एट दैट and based on that you decide on your second intervention.
बहुत इंपॉर्टेंट पॉइंट है. वेरी गुड सर. यूजुअली लोग क्या करते हैं, मॉनिटर का जो अलार्म चल रहा है उसको साइलेंट कर देते हैं. आपने बोला मॉनिटर कंटिन्यू करो. वेरी गुड. Sheikh sir, take home final point from your sir because you're senior most.
I think it's nothing left for me, but what I can say is that no one patient is similar to the other patient.
Yes.
No one intervention is identical for other patient, and in the same patient, no one intervention is like the same in the next 2 hours, 4 hours. So you have to keep on changing and customized based on the individual patient and individual scenario.
I give it over to Kiran sir and Pawan sir. Thank you.
Pawan, anything you want to add more?
That's all, sir. Your concluding remarks.
So thank you very much, all the panelists and moderator, Dr. Maninder, Dr. Sheikh, and Dr. Pawan, Satyen, and Nikhil. Thank you very much. आप लोग कह रहे थे कि स्लाइड शेयर नहीं किया एक दूसरे को, but it was not looking like that. Everything was well planned and well. तो बहुत ही अच्छे से आप लोगों ने तैयारी की.
कर देना, फायदा कुछ नहीं होता है.
But I would request a few of the comments from our senior pediatricians of Chhattisgarh as well as from across the nations. They are also joined us. Dr. Sarabhai sir, Dr. Pawan sir, please comment on our session, sir.
Kiran, it was one of the best panel discussion I have ever attended. That is one. And Dr. Maninder, it looked as if you are the external examiner for the MD student. And that was wonderful. And I tell you, I want to congratulate everyone because every student has passed. So the things were beautiful, beautifully managed. Congratulations
Kavinder
again.
sir, Maninder is a tough examiner. Even if you say, even I'll tell you one thing. Even if you have an exam, what is called as open book exam, na, he will make our life tough. Open book exam I'm talking about. This is a closed book exam.
यार
But I must agree.
आप लोगों के सेशन को देख के ऐसा लग रहा था कि सारे स्टूडेंट्स जो हैं वो एक्सटर्नल से भी ज्यादा ब्राइट हैं. Dr. Sawan sir, please quick comment.
Excellent session.
Sawan sir.
Maninder, well moderated, and both the speakers earlier spoke very well.
Yes,
Dr.
very
Pawan
good.
and Maninder both, and all the students who participated in this discussion were excellent. Very good questions and very good answers, and very clear-cut indications given. So it's really very informative. We in the midnight we are
Sir, history में
खत्म ना हो चलते रहे. It's
सर ये अपने जो अपना ट्यूसडे ट्रेजर की हिस्ट्री का सबसे प्रोलॉन्ग डिस्कशन रहा है.
Yes,
और
yes.
2.25 घंटे हम बैठे हैं सर, और अभी भी ऑडियंस जाने के लिए तैयार नहीं है सर.
नहीं, मनिंदर तो सांस लेने नहीं दे रहा था ना, बीच में उठ के.
सर वो पहले ही कैबिट लगा देता है तो बड़ा डर लगता है कि आप अपने क्वेश्चन को कैसे ऑर्गेनाइज करना आंसर को. बट आई
एक्चुअली
मस्ट टेल
पैनल
यू
डिस्कशन जो वर्ड है उसको पूरा जस्टिस दिया है उन्होंने.
नहीं, Maninder is I mean he's a great, he put lot of efforts into it. He put lot of efforts.
Thank you, Dr. Maninder. So much of the praiseworthy words are there from all of us, and thank you very much all the panelists. I hand over mic to the our treasurer, Dr. Nile. Are you there?
Yes, sir. Yes, sir. Bilkul. I'm not
Just please
sleeping at all.
conclude the session.
I was listening the discussion and panel discussion, and it was really joyful and grateful to listen all the panelists and especially the moderator. And I think everybody has already praised, and this was the discussion which we were not able to sleep. We were always on the toe to listen to the answers. That was the best thing, I think. So thank you very much, all the panelists and the moderators, speakers, and all the doctors from Chhattisgarh and outside of Chhattisgarh who have joined. And thank you very much, CGAP President and our Secretary, which is not here, who is not here today, and our EB member Ashok Mehta for making this program successful. And we would, it will be, I think from the next time also, we will be having such good sessions on Tuesdays. So thank you very much all, and good night to all.
Thank you, Joshi ji, also for technical.
Thank you, sir.
Thank you. Yeah, sorry, Joshi ji, sorry. रात को नींद नहीं आएगी मेरे को. पिछले बार भी ऐसे ही हो गया था गड़बड़.
Thank you.
Thank you very much, and good night to all.
Good night. Thank you, sir.
Night.
Kiran sir, thank you.
Thank you very much.
Thank you, everyone.
Good
and
night, sir.
Really-
Good night.
Very Pawan, thank you, Nikhil. It
Thank you, sir. Thank you. Thanks a lot.
was really good. We'll be.
Thank you.
Thank
Sir.
you.
Thank you.